So this is a basic introduction on how to do a simulated ERCP. I have Dr. James Ryley, ST4 in University Hospital Sussex, and Peter, another gastrologist as well. So James has been signed up for OGDs but has no actual ERCP experience, so he's going to show us how to do an ERCP.
Great. Receive consent with the faculty design.
Yeah, of course. So important things with ERCP is it's a side viewing scope. So James actually can't see that much. He can see now that he's at the GOJ. He's turned a bit right and then turned a bit left into the pylorus. He needs to kind of get the pylorus in that position and to get his wheel upwards. And now he's hopefully gone into the duodenum. He's done a maneuver to get through that area. Now he's gonna lock his right wheel and he's gonna tip up and pull back in order to shorten the scope. So if we actually click on X-ray, we can see his scope is getting shorter. Keep on doing it if you can. Let's see.
Lost there.
Yeah, you need to try and I think okay. You're retroflexing. Yeah, there you go. Let's have a look at X-ray. Okay, that looks pretty short on X-ray. Good. So what are you going to do now, James?
So now I need to get into the pulse. So it'd be good to have it sort of at 6 o'clock. So
yeah,
I might move.
Yeah. So ERCP is all about small movements. It takes a bit of time to orientate. James needs to get a good view of his ampulla so that he knows where he can use his sphincterotomy appropriately. So this is a bad view so far.
Yeah, it's difficult to get it in the right place here.
So try and pull back. See what happens if you pull back. Just pull back slowly. Okay, so now you're coming out. So push in. Is your right wheel all the way to the right?
Yeah, it's unlocked now.
Turn it all the way to right. Lock it.
Right.
Wheel away from the mucosa. Push in slightly now. So that's usable. So essentially, James needs to somehow be below the papilla. So he needs that papilla to kind of be in the upper half of the screen, and then he wants the sphincterotomy to kind of go from here towards 11 o'clock. So main part about ERCP is actually
I think the lock wheel's
positioning.
That's the issue.
Well, that could explain itself.
Because I have to hold it down.
Okay.
That might be why.
Yeah, could be.
There you go. Yeah.
Okay, that's a decent position.
Because the lock wheel was broken. That's okay.
So where would you aim with your sphincterotomy?
So I'm going to go into there.
And then what direction do you want your sphincterotomy to go? Do you want it to go that way?
No, sort of perpendicular. Well, yeah, perpendicular to where I meant to.
So if you go flat and it goes straight, you'd go to PD. You kind of want your sphincterotomy to go up to 11 o'clock.
Is it white that going?
Yeah.
Open, close?
Yeah, I'm just going to push to start with.
Okay, so we get the sphincterotomy. So then, interesting thing about ERCPs is the extra bit different from a standard scope is the elevator. So James would normally have the elevator down to make sure any instruments don't come out. And then once it's out, you can then lift and lower it. And then if Peter opens and closes it, which is bowing of the sphincterotomy, you can see that it changes the angle. So that's it open now, that's it fully bowed, which helps with the direction. So you can see that sphincterotomy is going in roughly the same direction. Normally for a standard ERCP, we do a wire-guided cannulation. So James would get the sphincterotomy engaged and then use a wire. Just for the simulator, we're going to try and cannulate with the sphincterotomy itself without the wire. So he's got a good angle. Okay, and then we'd continually use X-ray to make sure we know exactly where we're going. So that is going a bit flat, so I'd worry this is going into the PD. Keep on going though. Okay, that's going up, going up, going up, going up. We don't normally use contrast. We just try and follow the trajectory of the wire to be sure it's going into the bile duct. Keep on going. Yeah, I think that looks good. That looks good so far. That looks good. Looks good. Looks good. Okay, so I'm going to inject some contrast now, and that's your bile duct. So normally James would have a wire going into the intrahepatics, and then after that he'd do a sphincterotomy. So we're going to set the settings up, and James needs to try
I need to
and
bring
get
this
his
out a little
out a
bit.
bit more. Yeah, so you
Yeah.
want to kind of see the cutting wire and see exactly where it's cutting.
This is annoying. This doesn't look.
Yeah. Obviously, you could argue that you can't see a stone, so you should do
Okay.
some trusting you.
Fine.
But yeah, so yeah, so you're cutting again the direction of the bile duct. Okay, good. That's a nice big cut for no stones present. So you can, and then after this, you do a balloon roll. So pull it back, and then put it back in, and then we can choose the extraction balloon. Obviously, there'd normally be a wire here that you'd feed this over. But yeah, that's going probably hopefully straightforward. Yeah, go higher up, go all the way to the hilum, and then Peter's gonna inflate your balloon for you.
I suppose.
Yeah, go there, Peter. Good, and then we're just gonna go straight and do an occlusion cholangiogram, which involves injecting contrast while the balloon is inflated, and James is going all the way down. We'd normally take an image about here just to confirm that the duct is clear. That's
Oh,
for
that's
the
the balloon.
ERCP, and it's a balloon.